Hi, my name is Charlotte Walker, and today I will be discussing my project addressing the breastfeeding gap in a medically underserved population. I would like to acknowledge and thank my committee member, Dr. Wonderlick, and my community member, Jamie Yost, APRN. I appreciate your time and dedication in support of this project. African American maternal infant health has been a focus area of healthcare for the past several years. African American mothers and infants face a number of racial health disparities, including breastfeeding. Breastfeeding has been shown to decrease risk of many chronic health conditions that disproportionately impact African American mother-infant dyads, including many childhood infections, diabetes, asthma, childhood obesity, and sudden infant death syndrome. Mothers benefit from increased maternal bonding, decreased risk of ovarian and breast cancer, and fast and postpartum weight loss. Despite this evidence, lack of access to breastfeeding support has left African American mother-infant dyads marginalized, thus resulting in higher uses of breast milk substitutes, also known as commercial formula. Literature and surveillance has demonstrated double-digit deficits when breastfeeding initiation, duration, and exclusivity rates are reviewed between African Americans and other ethnicities. Many African American mothers also face a disproportionate number of barriers, including lack of knowledge, lack of social and familial support, struggling with social norms such as the sexualization of breastfeeding, and employment barriers. African American mothers, particularly those with low income, return to work sooner than other racial and ethnic groups and are more likely to experience challenges of breastfeeding during work hours. The implementation of breastfeeding support programs has been associated with increased breastfeeding and duration rates. Unfortunately, the implementation rates of evidence-based breastfeeding programs are lower in neighborhoods with a large African American population. Creating a framework for a program that can be implemented in communities that are high risk for disparities, including larger African American populations, increased poverty, and areas that report lower education levels, can greatly impact the vulnerable families in these communities. The purpose of this quality improvement project was to determine if a breastfeeding support program increased post as compared to pre-intervention rates of breastfeeding initiation, duration, and exclusivity in African American mother-infant dyads. A literature review was conducted utilizing Medline, Sinhal, EBSCO, Ovid, and the Cochrane database systematic reviews. A search utilizing keywords and phrases such as African American breastfeeding disparities, African American breastfeeding, minority breastfeeding support, community breastfeeding support, and healthcare breastfeeding education resulted in 75 literature references. Recent surveillance and analysis of the national databases demonstrated differences in breastfeeding initiation, duration, and exclusivity of African American mothers when compared to other races and ethnicities. African American mothers were found to have a breastfeeding initiation rate of 66%, while breastfeeding initiation rates for Caucasians, 81%, Hispanics, 81.9%, and Asians, 82.4%, are markedly higher. The margin gaps are wider for breastfeeding duration and breastfeeding exclusivity. Researchers also cited the lack of social justice as African Americans are at increased risk for lower breastfeeding rates and lifelong health disparities. The cause of breastfeeding disparities in the African American community is complex and requires an interprofessional and systemic approach to resolving. Researchers cited that access to breastfeeding support in the community is fundamental to closing the breastfeeding gap in the African American community. Areas with large African American populations are less likely to have access to a breastfeeding-friendly hospital or institution and have little to no access to community breastfeeding support. Mothers in the African American community lack access to culturally competent breastfeeding education programs, as many traditional programs, such as the La Leche League, are disjointed and fail to address the unique needs of mothers in the African American community. The literature indicates that the lack of interpersonal support is a barrier to breastfeeding for many African American mothers and mothers that and that mothers perceive to have interpersonal support, spouse, grandmother, or friends, were more likely to initiate and continue breastfeeding. Qualitative studies revealed limited access to breastfeeding role models. Lack of generational breastfeeding history in the family left mothers feeling isolated in the postpartum period. Many family members would object to breastfeeding in public, at family functions, or would discourage breastfeeding at all. Breastfeeding support programs are less effective if the interventions are targeted solely toward the mother-infant dyad. A family-centered approach is necessary to assess for interpersonal support barriers. Individualized interventions that educate and empower not only the mother, but also her support circle are critical to increase the interpersonal breastfeeding support. A review of recent qualitative and quantitative studies noted lack of healthcare provider support as a persistent theme for discontinuing breastfeeding among African American mothers. Research also demonstrated that most healthcare providers understand the benefits of breastfeeding for both maternal and infant health, but cite the lack of education and self-efficacy negatively impact their abilities to support breastfeeding mothers. There's a lack of formal breastfeeding education programs, despite evidence demonstrating that formal education improved knowledge, attitudes, and confidence of breastfeeding support. Qualitative studies cited that mothers received differential treatment from healthcare providers regarding breastfeeding. Mothers highlighted that providers were indifferent or oppositional about breastfeeding, inconsistently provided support after hospital discharge, and lacked cultural competency, resulting in the discontinuation of breastfeeding. Furthermore, research demonstrated the lack of organizational buy-in to support breastfeeding in the community. Community primary care organizations consistently lack implementation of breastfeeding-friendly office guidelines. Studies revealed that clinicians cited limited time during health supervision visits, limited knowledge of ICD-10 codes that address breastfeeding, and inadequate knowledge of community resources as barriers of breastfeeding support. The theoretical framework utilized for the intervention development included the Tri-Core Breastfeeding Conceptual Model for Primary Care, established by Dr. Deborah Bush in 2013. The Tri-Core Breastfeeding Model emphasizes three principles of lactation promotion and sustainability for the mother-infant dyad, including maternal self-efficacy, maternal and professional lactation support, and maternal and professional lactation education. The Tri-Core Breastfeeding Model involves an assessment of barriers, maternal confidence, milk supply and latch, the infant, and employment, school, and social support. Assessment questions for mothers should be open-ended and should encourage a dialogue to take place between the healthcare provider and the mother. The assessment provides the healthcare provider insight with the perception of breastfeeding progress, and the mother provides an opportunity for reassurance, education, and intervention where necessary. The model provided self-efficacy, lactation support, and lactation education strategies to implement in the primary care setting. Providers were encouraged to promote a breastfeeding-friendly office environment, to encourage familial support and attendance of the well child checks, and to avoid ineffective support through conflicting advice. Breastfeeding education was provided by trained staff at each well child check, in which at least one identified support person was encouraged to attend. Individual appointments provided lactation support, promoting mastery of breastfeeding skills for mothers and the support team. Offices implemented a breastfeeding-friendly protocol to further promote their breastfeeding amongst patients, utilizing the American Academy of Pediatrics breastfeeding-friendly office guidelines. Lactation education was provided to identified staff members through an evidence-based program approved by the International Board of Lactation Consultant Examiners. Literature was provided to mothers regarding their rights as established by the Affordable Care Act to decrease barriers faced with continued breastfeeding and returning to work or school. A qualitative quantitative exploratory design via retrospective chart review was utilized to evaluate the impact of the intervention. De-identified data was collected in the 31-day pre- and post-intervention period onto a data collection sheet. This design served as a safe and cost-effective way to implement and evaluate the program. The study took place at a federally qualified health center that served a large population of medically underserved African American mother-infant dyads. Implementing the program at a federally qualified health center addressed the noted lack of access to breastfeeding support in African American communities, particularly those who are in lower income and underserved. To address the lack of breastfeeding support, 3 foundational areas were addressed. 3 pediatric clinicians completed a formal breastfeeding education program to earn the title of a certified breastfeeding specialist. Education was provided to the remaining clinicians and pediatric support staff to increase breastfeeding promotion and advocacy. Lastly, strategies presented by the AAP's breastfeeding-friendly guidelines were implemented, such as seeking collaboration with Women's Health Department to expand breastfeeding education efforts, introducing the discussion of breastfeeding as soon as possible with families, working with the local hospital to schedule follow-up postpartum appointments within 24 to 48 hours after discharge, and evaluating our practices of distributing free commercial formula. The program consisted of 100 electronic medical records. 50 EMRs were reviewed during the pre-intervention phase and 50 were reviewed in the post. Inclusion criteria for the program included EMRs with documentation indicating that there were African American mother-infant dyads, the infants were under the age of 12 months, the infants who were established patients and they had been seen at the clinic during each phase of the program, including the pre-intervention, intervention, and post-intervention phases. A chi-square was utilized to evaluate the question of breastfeeding initiation prior to the infant reaching 1 month of age. The response for this inquiry was yes or no, providing nominal data. The chi-square analysis is optimal for analyzing nominal data in a pre-post design with 2 or less variables. The breastfeeding duration inquiry provided ordinal data and was utilized it was analyzed utilizing a Mann-Whitney U test. And finally, breastfeeding exclusivity also utilized data that required a ranking of responses, thus providing ordinal data. The Mann-Whitney U test was utilized to analyze breastfeeding and exclusivity data as well. The data collected revealed that breastfeeding initiation, duration, and exclusivity rates increased in the post-intervention timeframe. Breastfeeding initiation and duration increased by 37% and 82% respectively. Most notably, breastfeeding exclusivity increased from 0 mother-infant dyads reporting breastfeeding exclusivity in the pre-intervention group to 5 mother-infant dyads reporting exclusive breastfeeding in the post-intervention group. The data analysis revealed no statistical significance between the pre- and post-intervention groups. As it relates to the impact of the intervention, it has demonstrated clinical significance in having breastfeeding support in underserved areas. Despite the lack of statistical significance, the patient population saw an increase in breastfeeding. Many mothers had also provided feedback about how the program has been instrumental in breastfeeding continuation, especially during the COVID-19 pandemic where inpatient and outpatient lactation support was scarce. Limitations for the program included changes related to COVID and staffing, a short data collection period, the use of a convenience sample, and a small sample size. The COVID-19 pandemic impeded upon the education outreach strategies that were a part of the original program design. The cancellation of in-person prenatal education courses removed a direct education opportunity from expectant mothers and their personal supports. To decrease the impact of this barrier, pediatric providers were provided an in-service to reinforce the importance of breastfeeding education to families at each encounter. The program was also designed for 10 support staff to have formal breastfeeding education to strengthen our support and delivery efforts. However, the COVID-19 pandemic shifted organization focuses, and support staff were needed to assist at multiple testing and vaccination sites throughout the county. A similar education strategy was implemented with our pediatric support staff, and an in-service was conducted to discuss the importance of breastfeeding and our program initiatives. This empowered the support staff to offer breastfeeding support services during patient intake and to schedule appointments with the breastfeeding support team when indicated. The 31-day collection period resulted in 50 pre and 50 post-intervention EMRs utilized in the data analysis. Utilizing a small convenience sample impeded on the ability for a statistical relationship to be formulated and limited the generalizability of the study's results. To improve the data analysis, the author consulted with the university statistician to ensure the appropriate analysis tools were utilized. The implications for this study include continued research on leveraging the patient-clinician relationship of the primary care pediatric provider to provide breastfeeding support, especially in underserved communities. The continued work should evaluate the current breastfeeding support program and to seek to expand its efforts throughout the organization to validate the framework that was implemented by the author. Similarly, organizations will need to evaluate their current breastfeeding support efforts or lack thereof and utilize evidence-based practice guidelines for their practice. Formal breastfeeding education for a diverse group of clinicians, early maternal breastfeeding education and support, cultural competence, and access to resources to address social economic barriers must be addressed when developing breastfeeding support efforts. Research efforts should continue efforts to establish a gold standard protocol and guidelines for outpatient breastfeeding support programs. Furthermore, research efforts must focus on long-term health outcomes of African American mother-infant dyads when breastfeeding support is implemented. Policymakers must provide incentives for breastfeeding support and advocacy among organizations as a preventative measure to decrease the risk of chronic illness. The development and implementation of an evidence-based breastfeeding support program remains a priority in the maternal child health care. This is especially prominent for African American mother-infant dyads who lack access to education and support despite being faced with several chronic illnesses and disparities. Formal breastfeeding education for pediatric primary care providers, implementation of an evidence-based breastfeeding support program guidelines, and maternal education and support access are critical to addressing the breastfeeding disparities gap. The research conducted by the author is consistent with the current literature and is on topic and provides additional aspects for consideration when developing further research studies or developing intervention frameworks. Education and access are fundamental in breastfeeding education, and access to breastfeeding support will increase the health equity and improve the outcomes for this marginalized population plagued by chronic health disparities. The references here were utilized in the presentation and throughout this research study. I will now take the opportunity to open up for questions. I thank all of you for listening to my presentation. Throughout this presentation, I really enjoyed my ability to be able to serve this marginalized population, and I was able to also serve my coworkers as well, with allowing several of my coworkers to send recommendations, particularly some of our male pediatricians who may not have had as much knowledge or access to breastfeeding or feeling comfortable in providing breastfeeding support, but having that team where we could take referrals was really helpful to them. I remember a situation where I was able to help one of our pediatricians because the mom was not feeding the baby enough and the baby was losing weight. And I was able to utilize his concerns as well as my training now as a certified breastfeeding specialist to be able to come up with a plan to ensure that that infant was growing well. And it really helped support mom as well. So I just thank you all for the continued support. I thank you all for listening to this program, and it has been such a joy to be able to provide this service. So I look forward to interacting with all of you in the comments and reading and answering your questions. Thank you.